Chapter 13, Nursing Care During Labor and Birth. So in the following PowerPoints, we're going to talk about the nurse's role in caring for a woman during her labor and delivery. Some issues just to review for new nurses, especially in that novice role, is understanding the influence of pain associated with birth. Knowing that it's not necessarily a realistic goal for somebody to have a pain-free experience, even with medication management. Understanding how women labor, what is physiologically occurring at the time too, can kind of help a novice nurse educate their patients on realistic expectations for their labor and birth. Inexperience and negative experiences. As nurses, we want to keep our patients safe, and especially during their labor and birth, we want them to think about it as a positive experience, welcoming their new member of their family. So sometimes a little bit of that inexperience in a novice nurse can potentially impact the way our patients experience birth, perhaps not giving enough patient education or having, again, unrealistic expectations. So it's just important to kind of look at that bigger picture and understand physiologically what's occurring and what the roles of the nurse are during labor and delivery. Unpredictability, very big in obstetrics. We could have a patient who is, for example, hypnobirthing, very calm, very zen. She is coping well with her pain and her labor. And then in another room, we could have a patient who maybe just started contracting an hour ago and is now in very active labor and uncomfortable and about to imminently deliver. So it's a lot of unpredictability. It could be all calm or all in the moment, feast or famine. Intimacy is another big issue, especially for a novice nurse in labor and delivery. Some patients want to be kind of liberal and free, and they might choose to labor with minimal amount of clothing, and we're in a very intimate area for a woman, so it's a very interesting kind of pickup on how nurses start to develop their comfort level with patient intimacy as well. After a patient is admitted to a birth facility for their labor and delivery, a lot of protocols start kind of rolling in. How we monitor patients, what the standard of care is for assessing vital signs, cervical checks, all of that. Before patients even get admitted, they have to understand that decision to kind of enter the birth facility. Most patients nowadays do a little bit of prenatal education. Prenatal education can review when a patient should come to labor and delivery for evaluation. A lot of the prenatal education talks about the 5-1-1 rule. 5-1-1 is contractions 5 minutes apart, lasting about a minute, and all of those symptoms occurring for about an hour. That is a standard kind of rule of thumb as to when patients should be coming to a labor and delivery facility. So that, again, just to review, that is contractions every 5 minutes, lasting about a minute, and that occurs for at least an hour prior to the birth, prior to entering a birth facility or going to your hospital where you're choosing to deliver. And that is kind of laying that foundation of early labor so a patient can come in and be admitted in active labor. Number and duration of any previous labors, also a really big impact. If this is a patient who is on her 4th or 3rd baby and her previous labors lasted less than 10 hours, perhaps she doesn't have to wait for that 5-1-1 rule and can come in a little bit earlier for an evaluation. So it's important to know your patient's past medical history, especially in particular to obstetrical experiences prior to counseling them. Other things that should be taken into account: distance from the hospital, especially if these are patients who have a long drive or the weather might be a little faulty. It's important to include that safety in their assessment too as to when they come to the hospital. Available transportation. Again, we really want to reserve our ambulance use for true emergencies, but in some cases that has to be the patient's mode of transportation, so understanding that impact as well. Child care needs, especially if this is a second, third, fourth time parents. They have to think about where their other children would be, especially during an unpredictable time like labor and birth, and understanding other risk statuses for these patients as well, if they are high risk patients or have a need for antibiotic therapy prior to delivery. So it's important to consider all those things when counseling patients as to when to come to the hospital. Admission to birth facility, nursing responsibilities during admission. So now we have counseled our patients. They have come, let's say, at the appropriate or ideal time for their admission to a labor and delivery unit, which is typically admitting patients in active labor. And that might be a little different based on each individual facility in terms of dilation and clinical picture. After a patient is admitted, it's important for the nurse to establish a therapeutic relationship. This is a highly vulnerable time for these patients. A lot of them might be, especially if they're first-time parents, they might be nervous. Perhaps they've had other experiences in the hospital, or maybe this is their first time. So they might be carrying some other feelings on board as well. So it's always important to make families feel welcomed, make them feel safe, establish, a relationship with them. Determine family expectations. Is this a partner who's going to be very involved in mom's labor process, or is he a partner that perhaps wants to be a little bit more removed? Understanding the family dynamics as well is very important. Is this a single mom? Are these same-sex couples? And understanding how each partner wants to be addressed as well is incredibly important. Conveying confidence, especially for that novice nurse. This is a challenging area for them. Kind of putting your best foot forward and knowing that you're going to keep your patient safe, and that is your main goal during the labor and birth. Assign a primary nurse. In most institutions, again, it's very individual. Patients in active labor will have a 1-to-1 nursing ratio, meaning that they have a primary nurse who is caring for them during their labor. Understanding the use of therapeutic touch for comfort for some patients, but also knowing and understanding that some patients prefer to act and work a little bit more independently, might not be as receptive to that therapeutic touch. Respecting cultural values is really, really important, especially surrounding labor and birth. A lot of cultures have maybe special traditions that they would like to institute during their stay on labor and delivery and during their newborn period. It's always a great conversation starter with families, especially again for novice nurses. Hey, is there anything special you'd like me to observe for you when this baby is born? Is there any type of special prayers? Do we need the room in a particular kind of environment, like very calm and quiet, or so on and so forth? So it's really great to have those types of conversations after a patient's admission. Other than welcoming our patients, kind of establishing that rapport and really laying down the foundation to safe patient care, it's also the primary nurse's responsibility to perform a focused assessment on her two patients, the fetus as well as the laboring patient. A focused assessment on a fetus can include establishing a baseline fetal heart rate. Fetal heart rate normal ranges are 110 to 160. We want to take a listen to the rate and rhythm of the fetus heart rate. We want to assess any presence of accelerations in their fetal heart tracing, as well as an absence of decelerations. And later on this week, we'll be reviewing fetal heart strips in class, so we'll be able to kind of look through what decelerations could mean and nursing interventions for them. Another thing we'd like to do as well is establish maternal vital signs. We want to identify any risk factors, right, for keeping our patients safe, any risk factors for infection. We want to establish their baseline temperature when they come in, hypertension, hypotension as well. Other important focused assessments are, is this an impending birth? Is mom showing us body language? Is she making grunting noises that would exhibit that she's perhaps moving forward in her labor and maybe getting ready for the birth? Is she bearing down? Does she feel an urge to push? Other responsibilities include database assessment, essential information from the client. For example, past medical history and past surgical history. Again, we talked about that fetal assessment and establishing their labor status. Is this patient contracting every 2 minutes? Are those contractions strong? Again, her body language telling us that they're so if she has no anesthesia on board. Is she ruptured? Has her bag of membranes ruptured at home or in the hospital? What was the time of that rupture? What is the color of the amniotic fluid and the amount? Amniotic fluid should also be odorless. So understanding those kind of key baseline information is a great way to start kind of getting that whole picture for our patient. Most nurses also perform physical exams on their patients. They might listen to their heart, they might listen to patients' lung sounds as well. The next following slides are something that can be performed during a primary nurse's baseline assessment for her new patient on labor and delivery. And these are called Leopold's maneuvers. Leopold's maneuvers determine the presentation and position of the fetus and aid in the location of fetal heart sounds. It also gives nurses a perception of how big this baby is. And as a labor and delivery nurse goes from novice to expert, she might be able to start kind of recalling the size of a baby through Leopold's maneuvers. So is this a very small for gestational age baby? Is this a average term feeling baby? Or is this a LGA or large for gestational age baby? Great to determine those as well because they can actually be a risk assessment for patients and complications during labor and birth. In the first photo that we see here with Leopold's maneuvers, we can see that the nurse is palpating for the fetal back as well as the fetal legs. We see that continued as well on the next slide, slide 8 of 32 here. And on slide 9, we can see the nurse's assessment for the fetal head, that round presenting part way low into the pelvis. And that part might be a little bit more challenging to palpate depending on where in labor this patient is. If that fetal head is very engaged way deep into the pelvis, it's going to be challenging to palpate that. And our last Leopold's maneuver there, we can see, again, that fetal head palpation and the front of the fetal parts presenting palpation. So like hands and arms we can see being palpated there in that photo. Continuing on with nursing responsibility during admission, part of the admission procedure is we want to notify the team in which the patient will be managed by. Team members could include resident physicians, attending physicians, and nurse midwives. We want to let them know about the patient's status. The patient has arrived, the patient is this far dilated, the patient is requesting pain management or is not. We want to let them know the information we obtained from the fetal heart assessment as well. Obtain any orders to care for the patient, such as laboratory tests. Perhaps these patients might require a CBC to be drawn upon admission, as well as a blood bank sample. Patients on labor and delivery, all patients across the board are at risk for hemorrhages. So it's highly important that we obtain labs that are going to be reflective for us to care for our patients safely, especially in the event of a hemorrhage. So a blood bank sample is typically required upon admission so that if the patient requires the need of a blood transfusion, we're able to match their blood sample to something in the blood bank. Most labor and delivery units, not all, but most I would say, might require their patients to have IV access. They might initiate a saline lock versus running IV fluids. Most institutions require consent forms from their patients, such as labor and delivery, care consent, as well as an anesthesia consent. Most patients in most institutions on their labor and delivery admission are seen by an anesthesiologist. They assess the patient's airway. They listen to their past medical history. They talk about pain management services such as epidurals, and they typically always review the risks and benefits of general anesthesia as a backup method to any type of anesthetic these patients might require in true obstetrical emergencies. Other responsibilities after admission include, again, that fetal heart assessment. What is the baby's fetal heart baseline? Is it staying within the normal ranges, or is it exhibiting a decrease in fetal heart rate baseline or an increase, and what would those findings indicate? Again, amniotic fluid, we want to assess the status of the patient's membranes. Has she ruptured spontaneously or artificially? Artificially is also called an AROM. An AROM is considered a method of augmentation or adding to a patient's already established labor. Other maternal assessment findings would be vital signs, contractions, labor progress. Patients will require eyes and O's, as well as their response to labor. And these are assessments that might be ongoing for the labor and delivery nurse. Certain institutions have certain guidelines as to how often a patient in labor requires vital signs, depending on the intervention that they have. For example, a patient who has a running epidural most likely will require more frequent blood pressure readings than a patient with no anesthesia. And that could be because of the impact that the epidural might have on a patient's baseline blood pressures. Contractions. We want to make sure that the patient is continuing to make progress and that we're moving forward with delivery. So that might be an assessment that can indicate whether or not a patient would be a candidate for augmentation or adding to their already established labor. We also want to watch the response to labor. For example, if an intervention is performed to augment labor, such as the addition of IV Pitocin or that AROM as discussed before, we want to see mom's response to it. Does she continue to make progress in labor, as well as the fetal response? Is the baby stressed out by the intervention? And if so, how do we manage that? We also want to assess the support person's response. Are they somebody who is very engaged in the healthcare? Are they somebody who kind of stands back and is more quiet and observe maybe, and just kind of integrating that into our patient's care as well? Application of nursing process, false or early labor. So when we talk about false or early labor, we're going to talk specifically about patients who are in the 0 to about 4 centimeter range, that early part of labor. This is the longest part of labor because it is so irregular. Patients can contract every 5 minutes for about an hour, and then those contractions can completely peter out and dissipate. So it can be a very frustrating area for a lot of women, especially first-time mothers, because of that irregularity of early labor. In false or early labor, it's important to evaluate the labor status and assess whether this patient is a candidate for discharge or hospital admission. Like I said previously, each institution is very different, and some patients will be admitted to a hospital when they're in early labor, while other institutions will strictly only admit patients in active labor. It really depends on the patient status, the maternal status, as well as the fetal status. Analysis. Analysis, again, getting our baseline information. How frequently is our mom contracting? Are these mild, moderate, or strong contractions? Are they regular in timing? Are they uncomfortable? Again, that realization that there is no painless birth quite yet. We haven't established that. So knowing that these contractions are painful is contributing typically to their labor status, hopefully getting that cervix to efface, which means thin out, and to dilate, which means to open up. Planning. If this is a patient who is kind of teetering on that early labor versus active labor, for example, she's contracting frequently, the contractions are painful, she is, let's say, 3 centimeters, so maybe 1 centimeter away from that active labor part, what would be her plan? Perhaps it might be feasible to have this patient ambulate for an hour or two and then reevaluate the cervical exam to see if she is ready for hospital admission. Interventions include reassurance. I cannot stress this one enough, especially first-time parents. They are uncomfortable. It's their first baby, and a lot of them are very nervous and even a little scared. So teaching them and having them understand that this is such a normal process and that it is okay, that their baby is safe and that they're safe, and it's again a normal process. And it might be a great idea to kind of give them some ideas of things to do at home that might help them find a little bit more comfort. For example, maybe taking a little nap if they can get enough kind of breaks in between their contractions, or taking a warm bath or shower to help relax them as well. Doing some teaching on when would be an appropriate time to come back to the hospital for a labor evaluation, and then evaluating your teaching methods as well. We want to make sure that these patients are retaining the information that we're educating them on. Sometimes it's a good idea to ask them again to repeat some of the information you shared. So, for example, my patient, Mary Sue. Mary Sue, can you tell me a little bit about some ideas that I had given you to try at home during your early labor? Tell me what you might like to do. And in that case, perhaps the patient does mention, oh, I would like to try a shower, I'd like to try a bath. So that would be a great way to assess teaching strategies. Application of nursing process and fetal oxygenation. We want to assess at frequent intervals the fetal heart rate, again, characteristics of amniotic fluid, maternal vital signs, and pattern of contractions. It's going to give us the best information as to how this fetus is oxygenated. Fetal heart rate most often is conducted by external monitoring. We use those external monitors to establish a fetal heart baseline, assess whether there's any accelerations in the heart rate, and the presence of any decelerations. We're going to be reviewing fetal heart monitor strips on our class on 2-6, so we can talk about what a baseline is, how we establish accelerations, and what the definition of some decelerations are. Getting our baseline information is going to give us the best tools in our assessment so that we can note if there's any changes and how to intervene from there. We want to plan. For example, if we're starting to see signs that birth is imminent, perhaps understanding the next kind of steps in second stage of labor would be beneficial to caring for our patients, and what equipment might be needed then. If we are monitoring our fetal hearts and we are noting some presence of decelerations related to timing of contractions, we want to do some nursing interventions that would promote placental function. In some cases, decelerations can be influenced by a disconnect in placental oxygenation, placental function. So we want to see whether or not some interventions that nurses can perform at the bedside would be beneficial to promote that fetal oxygenation. For example, repositioning patients might be a beneficial fetal oxygenation intervention. Decompressing any compression on the fetal umbilical cord, on the cord itself in utero, could be an intervention performed by the primary nurse at the bedside. We want to observe for conditions associated with fetal compromise. For example, fetal distress on those fetal heart monitoring strips. That would be fetal compromise right there. And how would we as bedside nurses promote safer care? What type of interventions would we use? We can use maternal reposition. We can administer oxygen at the bedside to our moms, more oxygen for our moms, greater oxygenation for our babies. And we want to be in open communication with the delivering provider team, whether it's the midwife team or the physician team. What concerns do we have as a group? What interventions have we tried? And what is the next step in our plan? Discomfort. Discomfort, again, really big in labor and delivery. We quite haven't discovered the painless birth yet, so it's important to have that conversation with your patients on how we can manage discomfort, but also have realistic expectations for pain in labor and delivery. We want to perform a baseline assessment. Everybody copes differently with pain, and pain is incredibly subjective. So my 2 out of 10 on the pain scale might be somebody else's 5 out of 10 on a pain scale. So it's important to remember that. We want to provide choices to enhance patient control. Um, Control, especially during labor and delivery, can be minimal. So it's great to find ways that we can really promote choices for our patients. And again, determine whether anxiety is contributing to their discomfort. The psyche can play a really major role in a patient's labor and delivery. And sometimes talking through those anxieties or what fears or worries a patient may have during their labor and birth experience can really help to kind of manage their discomfort. It can help to change the way they look at labor and delivery as their experience. We want to think about planning for pain management as well. Is this a patient who is considering an epidural or considering any analgesic pain management throughout her labor? And again, talking about how pain relief is not a realistic goal to have zero pain, but to talk about how we can manage discomfort. And again, the goal, healthy and safe delivery, goal for a positive birth experience. Interventions that would be great to be provided at the bedside to manage discomfort for patients include comfort measures, lighting, perhaps it's a night shift and we want to dim the lights a little bit, make it softer, kind of more inviting lighting so it's not that bright fluorescent kind of light. Labor is hard work. Is our mom is she diaphoretic? Is she sweating? Is she having a hard time with the temperature in the room because she's working so hard? Do we want to make it a little cooler in there for her? Um, Emptying her bladder too, encouraging her to do that at least once per hour in active labor to kind of allow that baby to have as much space as he or she needs to come into the pelvis. Positioning can play a big role too in managing a patient's discomfort. I like to tell my patients that the worst position for them to be is supine, flat in the bed, not moving around and just kind of bearing through each contraction. I encourage them to work with their bodies, find a position that works for them. Perhaps it's sitting upright, perhaps it's standing. Some patients even enjoy kind of leaning forward, letting their belly kind of hang low in front of them if they're having any back discomfort. Nurses can offer, again, that therapeutic touch, warm blankets, cool compresses, a little bit of massage, whatever that patient is receptive to. But highly encourage your patients to continue moving around. Keeping that pelvis nice and loose and open is going to encourage that baby to really come deep into the pelvis. Having a patient kind of reposition in labor too helps the fetal head maintain continuous pressure over the cervix, which helps moms to thin out their cervix, which is effacement, helps them to dilate their cervix as well. And we saw in a couple of those slides there just some ideas for positions for moms in labor. Hands and knees, side lying, and I thought a great visualization, those pictures there, was the integration of using what you have in the hospital. If a patient wants to get on her hands and knees, but she's not feeling like she can be comfortable down on the hard floor of a hospital, use your bed. Bring that head of the bed way up. Have your mom lean forward. You can be there to be supportive for the patient. You can engage the support person in the room and have them kind of maybe give some therapeutic touch or pressure massage for moms as well. Interventions. For teaching, we want to have some anticipatory guidance for our patients throughout their stages of labor. First stage labor is defined as active labor through complete dilation. So that's kind of like that nitty-gritty part where moms are having frequent contractions that are uncomfortable. These are painful contractions that are dilating their cervix. So great idea to have them reposition, warm showers, so on and so forth to kind of work with the pain and discomfort that they have. Second stage of labor is defined as a mom who is completely dilated and is having maternal effort or pushing and bearing down with each contraction. Second stage labor is also variable in the amount of time. For some patients, it could be a couple of minutes, while for others, they could be a couple of hours in that second stage of labor. So having a little bit of that anticipatory guidance might set you up for more success with your patient, teaching them how to push, what the effort we're looking for is, what the expectation is, and kind of getting them ready for that process of delivery. We can also review with them positions for second stage labor, depending on your institution, depending on what is currently going on with your patients. Most patients can reposition significantly in second stage labor. Some patients can deliver on their hands and knees, others can push sideline. And again, we really want to encourage that reposition for our patients because it helps that pelvis to stay nice and loose and open. It helps as well with the diameter of the pelvis, so this baby has plenty of space to kind of travel through the pelvis for their labor and birth. The next couple of slides, we can see some ideas of positions for second stage labor. So there's that hands and knees position, squatting. Squatting can help open up the pelvis at least by 20 to 30%. So it's a really great position to get patients in. You can see that semi-sitting pushing as well as sideline. Slide 25 of 32, you can see discomfort continued here. Some interventions that would be great for that primary nurse to consider: encouragement, especially if you have a patient who is in a prolonged second stage. Maybe they've been pushing for an hour or two. They're feeling like their efforts haven't paid off yet. Encouraging them that they're strong, that they're making progress if they are, being honest with them, supporting them through this. Giving of self, really kind of getting yourself engaged and connected to these patients. The integration of pharmacologic measures. Perhaps this patient needs some pain management in order to help them kind of cope and move through that second stage of their labor, and really integrating the care of that birth partner as well. Really significant role for these patients. It's always a great idea to evaluate the effectiveness of your interventions. For example, pain management. Let's say this patient had an epidural placed prior to becoming fully dilated. Let's say she is now in her second stage and she's pushing and she's making effort and she's continuing to make progress. We want to make sure that that epidural is still working at an appropriate level and that it is not having kind of breakthrough pains. It's important that nurses also ongoing perform evaluations of care for their patients. Preventing injury for our patients is also an important role for the primary nurse in labor and delivery. We want to anticipate birth time to prepare for delivery, any additional equipment that we would need, any safety equipment such as fetal equipment, oxygenation for them, suction canisters, intubation equipment, just as safety equipment to have on board. Analysis. The client is very vulnerable both before and after delivery. This is an incredibly challenging time for her and a lot of physical effort to get that baby out. So we want to make sure that we're considering our patient's vulnerability during this time. Planning and preventing to minimize injuries. We want to perform some perineal support, that support over the perineum. We can do that manually with our hands while a patient is pushing to kind of decrease the risk of extended or large natural tears that can occur when the baby is being delivered vaginally. Interventions include transfer to a delivery room, and again, that's very institutional specific. Some hospitals have just labor rooms, and when the patient is ready to deliver, they transfer them to other rooms, while others do it all in one room. So it depends on where you're practicing. Positioning for birth. Like I said, we did a great job before encouraging our patients to reposition, so we want to just communicate what our position for birth might be with our provider team. And again, protecting and supporting that perineum. In slide 27, we can see a nice visualization of a fetal head crowning on the kind of lateral view as well towards the bottom of that picture there in that slide. In slide 28, we are seeing the delivery of the fetal head. We can see the healthcare provider there assessing for any cords behind the fetal head after the fetal head is delivered and reducing that umbilical cord there. We could then see the provider's hands kind of guiding that fetal head out, helping to deliver the shoulders through the pelvis there and getting ready for the rest of the birth of that baby. Nursing care during the late intrapartum period. So these are responsibilities for the primary nurse during birth. And again, This can be very institutional specific as well. Preparing a delivery table so that we have all our equipment needed for our delivery team when they arrive. Just having all the cleansing equipment that we would need for cleaning our patient's perineum and supporting pericare postpartum. We want to support our patients and our partners during final pushing efforts. Again, that anticipatory guidance, teaching on what to expect, what comes next, letting them know there's going to be, these healthcare providers are going to be in the room. They're going to be here for delivery. They're here for safety. We have open and honest communication, always kind of listen to our voices so we can guide you into what the next steps are. Initial care and assessment of the newborn. In most cases, the primary nurse is responsible for drying the baby, stimulating the baby to cry. In some cases, this could happen right on the maternal chest, while in other cases, the baby might be moved to a little fetal assessment area within the delivery room so that they can be assessed and cared for by the pediatric team. We want to manage the administration of medications. Typically, oxytocin through the IV is administered in the postpartum period to help that process of involution, which is when the uterus comes down to kind of a pre-pregnant size, as well as to help with the removal of the placenta and to encourage the placenta to detach from the uterine wall. Postpartum oxytocin also helps control maternal blood loss and prevent maternal hemorrhage. In slide 30, we can see of real photos there of a vaginal delivery of a baby. We can see that healthcare provider giving a little bit of that perineal support in photo B with that sterile towel, kind of guiding that fetal head out there. The baby then restitutes to either the right or the left side. That's when we can see that baby's head turned a little bit, and the healthcare provider kind of guiding those shoulders under the pubic symphysis, bringing that baby kind of forward in their position so that mom can see them a little bit better there in photo G, and bringing that baby up to a maternal abdomen for the nurses to dry, stimulate, bulb suction that baby with any kind of secretions that we would have. In that last photo there, I think it's photo I, we could see the delivery of the placenta, the amniotic membranes there being delivered with it as well. Nursing care during late intrapartum period and immediate postpartum period. So what are some of our responsibilities after birth? We want to manage mom's risk for hemorrhage, right? We talked about the initiation of IV oxytocin. We want to care for the infant. We want to administer those APGAR scores, which are scores in cardiopulmonary function administered usually at 1 minute of life, 5 minutes of life. And there are greater indications for administering at both 10 and 15 minutes of life if indicated. But most commonly, they are done at 1 minute and 5 minutes of life. And we look at fetal color, their tone, we look at their respiratory effort, their irritability, and we assign scores based on those markers and their physical presentation. We want to support thermoregulation, that integrating that skin to skin care, keeping baby nice and dry, maybe with a nice dry hat as well to really promote temperature stability. We want to identify our infant by placing infant ID tags on the baby as well as on the parents. We want to care for the mom, again, assessing a risk for hemorrhage, promoting comfort, perhaps initiating breastfeeding, and promoting early attachment for families. Our last slide here, quick question. A laboring woman is lying in the supine position. The most appropriate nursing action is to A, B, C, or D. And I hope that you'll be able to answer this question with success after this presentation.